Welcome back to Crack the Cure series with me, Kavya Tendril. Today we'll see the continuation of menstrual cycle and its irregularities. This is part 2. The video link for part 1 is in the description to check it out. If you have not subscribed to our channel, do subscribe for more interesting videos like this and as well press the bell icon so that you will receive a daily video notification. Yesterday we have seen about the normal menstrual cycle and physiology, menstrual cycle irregularities, the terms only. Today we will continue with amenorrhea and menorrhagia, identification, etiology of these two disorders. Amenorrhea is basically absence of menstruation. So there is absence of menstruation, bleeding. So what causes or what is the where is the bleeding is from the shedding of endometrium. Endometrium is nicely vascularized by uterine arteries. Uterine artery blood flow is increased by estrogen. So estrogen is released in response to FSH. FSH is released in response to GnRH. So although there is bleeding in the uterus, that is shedding of endometrium, and the menstrual bleed is present in the uterus cavity, it is not coming out. So there could be any pathology at genital tract also. So it is said because amenorrhea, when we are investigating amenorrhea, the etiology of amenorrhea could be at the hypothalamus, pituitary, ovary, or the genital tract. Amenorrhea is basically of physiological and pathological. Physiological, it is basically pregnancy, lactation, and after menopause. Pathological, we will see later. Again, amenorrhea is two types. One is primary amenorrhea, secondary amenorrhea. Secondary amenorrhea is a female already has a history of menstruation, but for more than or equal to 6 months, now she is complaining of amenorrhea. Now, primary amenorrhea is basically who to suspect. At 12.5 years of age, a female child should menstruate, but she is not menstruating. Let's wait till 14 years. If she is not still menstruating in 14 years, next go for evaluation of secondary sexual characters. Secondary sexual characters is not present and present. If secondary sexual character is present, then wait till 16 years. In 16 years, also we should check for menarche is present or not. Now in this case, menarche which is not developed at 16 years and secondary sexual character which is not developed or attained at 14 years are considered to be primary amenorrhea. If the female develops or attains menarche at 16 years, that is called as delayed puberty. Coming to causes of amenorrhea, it could be of the cause at hypothalamus, pituitary, ovary or genital tract we have discussed earlier, and thereby the causes could be of chromosomal causes like Kallmann syndrome, endocrine cause very important, adrenal pathology, diabetes, juvenile diabetes mellitus, and hypothyroidism. Nutrition cause we have discussed yesterday that minimal 22% of fat is needed for menarche, thereby nutrition is one of the important factors as well as some environmental factors. Coming to ovary, there can be Turner syndrome, Swyer syndrome, PCOD or primary ovarian failure also that in turn cause amenorrhea. Genital tract disorders, especially if at all there is any obstruction of genital tract like imperforate hymen, absent vagina, atresia of cervix, that is imperforate hymen, absent vagina and atresia of the cervix, there could be obstruction causing amenorrhea. In normal uterus, there could be refractory endometrium, tuberculosis, and absent uterus, that is Mayer-Rokitansky-Kuster syndrome. These are the some causes, pathological causes for amenorrhea. Coming to investigations in amenorrhea, one thing to see is whether the person has developed secondary sexual character or not. She is not developed, she has developed, and we have seen hirsutism. Hirsutism directly will code out to a PCOD, adrenal tumor or uterine tumor investigation. Now, if she has not developed secondary sexual character, check for height. If she is normal, check for FSH-LH to note where the pathology is. FSH-LH is low, it means pathology is higher level. Is high, then go for the pathology at lower level so that you do karyotyping. If she is short, again do FSH-LH to check where the pathology is. If it is low, it is an intracranial lesion. If it is high, the pathology is down. That is a Turner syndrome, especially causing presenting with streak ovaries. Now, if she had present with secondary sexual character, then go for checking uterus is present or not. Uterus is present, it means there could be enlarged uterus, outflow is obstructed, that is cryptomenorrhagia, or it could be of normal uterus. So in that case we will go for hormone assay, FSH, LH, prolactin. Everything is normal, there is delayed menarche, If LH is more, pointing towards PCOD, FSH is more, that is FSH is more, but estrogen is not produced, so the pathology is at ovary. Now everything is low, FSH, LH, it means the prolactin are low, that is the pathology at higher level. Pituitary hypothalamic failure. Prolactin is more, it signifies that it could be of hyperprolactinemia or prolactinoma tumors. This prolactinoma, if it is present, we need to again go for skull X-ray, because this prolactin can cause calcification in the lesion itself, that is called as pituitary stone. Next is the uterus is absent. Directly go for karyotyping. We'll see if it is absent uterus, that is Rokitansky-Kuster-Hashel syndrome. 46XSY is present in the karyotyping, that is Y chromosome is present, that could be testicular feminizing syndrome. With this basic idea, we are completing investigations of amenorrhea. Coming to menorrhagia, it is basically increased in amount or duration of bleeding. It is because of increased PGE2 or decreased PGF2 alpha. Now, if at all a female from perimenopausal or childbearing age coming to us with abnormal uterine bleeding complaint, then do a dilatation curettage and endometrial study to rule out CA endometrium. Next is fibro implant releasing 14 microgram of levonorgestrel for menorrhagia is still under trial. Puberty menorrhagia causes is very simple. First is pituitary cause, U for uterine cause, B for blood dyscreasis, and after B you have C, so it is PCOD, and ER, so liver as ER, so ER and ER, liver disorder, T for genital tuberculosis. These are causes for puberty menorrhagia, to make it easy to remember. Next, the leiomyoma subclassification system. It is given by FIGO, that is it is ranging from 0 to 8. So 0 is pedunculated intracavity, it is present in the cavity itself. Next is less than 50% of intramural, that is in the wall of the uterus. More than 52 is more than 50%, like less than 50%, more than 50%. The lesion is like from the cavity to serosa, direction towards that. The number is also directed towards that. 1 and 2. 3 is 100% intramural, and that is in the wall of the uterus, but it has some contact with the endometrium. 4 is the intramural itself, no contact. 5 is now it has reached to serosa, that is this part is serosa, so it reaches serosa, subserosal, but more than or equal to 50% of serosa. Here in 6 it is less than 50% of intramural, subserosal placing. Next, 7 is subserosal pedunculated. This is a peduncle and this is subserosal pedunculated. It is similar to the number 0 of leiomyoma. What is called a hybrid leiomyoma is 2 to 5. This is submucosal and subserosal, each with less than half the diameter in the endometrium and as well peritoneal cavity. So here is the peritoneal cavity, here is the endometrial cavity. So these 2 to 5 lesions can occupy less than the diameter in endometrial cavity and as well peritoneal cavities respectively. Coming to one important form of menorrhagia, that is metrorrhagia. Basically it is a intermenstrual bleeding, or it is actually defined as a acyclic bleeding from genital tract. It is only physiological, occurring at time of ovulation, where the female will complain of mid-menstrual bleeding, that is she will also have profuse sticky discharge and intermittent cramping pain. It is confirmed by basal body temperature, BPD chart or sonography, that is at the time of ovulation all this is taking place. A few months of combined oral pills will cure this ovulation bleeding, one thing. But if it occurs in elder women, always be cautious. It could be of earliest symptom of neoplasm, that is intermenstrual bleeding or acyclic bleeding could be of in elder age, it could be earliest symptom of neoplasm. So therefore we need to do a pap smear examination and do a diagnostic hysteroscopy and endometrial curettage for histological study of endometrial tissue, which is we can screen for CA endometrium. The histological picture in metropathia hemorrhagica, that is here the superficial layers are undergone necrosis and there will be cystic dilatation of the endometrial glands. And one thing to say in secondary amenorrhea is actually is important. Whenever we are going to manage secondary amenorrhea. This is to be mind. That is the patient is first pregnant because she already menstruated. Now she is not menstruating for more than 6 months. So I think if she is pregnant or if she serum prolactin level is more because prolactin will cause amenorrhea, right? Hyperprolactinoma. So if prolactin level is elevated, is there any clinically evidence of estrogen deficiency? Does she have any positive response to progesterone challenge test so that it can reveal there is progesterone deficiency? Is it a premature menopause or what are the levels of her serum FSH LH to rule out where the pathology is? This she is pregnant, prolactin level, FSH LH level, estrogen deficiency or progesterone deficiency to be ruled out in case of secondary amenorrhea management. Thank you so much for your patient listening.